Great. Thank you very much for that introduction. Let me pull up my slides here. Just a second. So many windows, so little time. There we go. Pull that up and let me know if you can see the full view of the slides.
Yes, we can see it now, Doctor. Thank you.
Perfect. Excellent. So as was mentioned in that excellent introduction, we want to talk about the client registry within the OpenHIE context. We know that identity management is becoming an increasingly pressing issue as we create these e-health infrastructures. We think about standardizing many aspects of the data, but often the patient identity piece can be one of the more challenging from a variety of perspectives. We're going to be talking about more of the technical approaches today, but hopefully we'll have a little bit of time at the end for discussion and Q&A if we'd like to expand beyond that. Here, I'm going to be talking about when people ask the question, well, what does the client registry in OpenHIE do and how does it work? We actually have specification documents for that within the OpenHIE document framework. And I'm going to be showing you both those documents, where they are and how you can dive in and go beyond the content even in this presentation. Our specification within OpenHIE is divided into 3 sections. We have an architecture section that talks about the overall architecture, so you can get a sense of the context of how different pieces interact with one another. We have a component specification section, which describes the functionality of each of the various components, including the client registry within OpenHIE. And then we have a data exchange specification. How should data move, be transferred and shared? What are the technical approaches to that? So I'm going to walk you through those today, again, specifically highlighting the client registry's focus. And of course, I use the red arrow to indicate that we're going to be focusing primarily on the component specification for the client registry. As you can see on this slide, you can see the location. If you go to guides.ohio.org, you can find all of this information. But what I want to point out is the OpenHIE architecture, as many of you know, and I think most of you are probably well familiar with it. Its goal is to standardize and harmonize healthcare data as much as possible to maximize the value of that data. If it's fragmented and non-standard, it's much harder to use and it's much less valuable. But what the architecture for OpenHIE fundamentally does is it standardizes who receives health services, the patient, and that's the client registry that does that. It standardizes who provides the healthcare services. Those would be clinicians, ancillary providers, etc. That would be the health worker registry component. Where the services were received, that needs to be standardized as well, and that is the facility registry within OpenHIE. What particular care and services were received, so those are the clinical observations, the clinical documentation, and that's standardized by the terminology service. What products may have been involved in treatment goes to the supply chain and inventory components, and then who has financial responsibility. All of these elements we try to capture within the architecture. So you've heard the basic domains that we want to standardize in. This is, I don't know about you, but I'm a very graphical learner, so this has always helped me. Here you can see where the client registry sits within the infrastructure. We have on the bottom, just to orient you, we have the various point of care service functions, from labs to logistics to finance, etc. They interact with the infrastructure, the architecture, through an interoperability layer that then interacts with the client registry. And you can see we've divided our components up into registry type services and business domain services, which includes logistic, finance, etc. So this is just, again, the 2-minute reminder of the OpenHIE architecture. Now let's move into more specifically talking about the OpenHIE client registry. So we know that patients' data is fragmented. It can be fragmented across different care locations, different ancillary care services, from outpatient to inpatient hospitals, to laboratory systems, to specialists, etc. Patient data is fragmented. And the high-level fundamental purpose of the client registry is to identify that person, individual people, across those different domains, so that their information can be stitched together to provide a comprehensive overview of the patient. So here again, just orienting you on the guides.ohio.org website, under the component specifications, you can see that there's a client registry. And we'll get to that in just a second. But I do want to point out, when we're thinking about the specifications or functionality of a given component like the client registry, there are not only functional and technical specifications, but there are also non-functional requirements. And we've laid out non-functional requirements independent of all of the components, because many of the non-functional requirements cross boundaries in the components. So we expect, for just by way of example, we expect the technologies in OpenHIE should provide a standard means of accessing the data that doesn't lock individuals into proprietary formats, etc. So that's an example of a non-functional requirement. Should be well documented. That's another non-functional requirement. So just to give you an example, those types of requirements are there as well. And again, you can dive through that at guides.ohio.org. Now on to the client registry. First of all, we document within the client registry specification what workflows it should support. Okay, so workflows are typical information gathering and sharing patterns within healthcare. So as you can see here, the client registry must support creating a new patient, updating a patient, being able to query the patient by 2 means, either by demographic data like names and dates of birth, or by unique identifiers. And so we have 4 total core key transactions that the client registry must support. By way of example, if I click on the first client registry workflow 1, that would take us to increased detail. So this is where things get really technical. And for those who are very interested in standards and information transactions, this is where you'd want to go. We document the maturity of the workflow. We document what standards may be used in this. We document assumptions. Again, in 30 minutes, it's hard to go through all the details, but you can clearly see that we've documented these. We have swim lanes and information flow documentation as well. And if we have time, I'd be happy to bring up a web browser and dive through more of this. Going back to the client registry, so we've seen the workflow requirements. Now we're talking about the functional requirements. The system needs to support a variety. So we have multiple client registry functional requirements. But these are the non-data exchange requirements for the client registry. We expect that there are appropriate rules for determining matches or individuals who are the same. It should be configurable. We expect that there's a blocking strategy, a strategy to quickly scan records. And we expect that the component should have an interface so that additional extensions to that functionality may be implementable. There should be default implementations, etc. So these, again, there's many here to talk about, but I would encourage you, again, I hope that that website, guides.ohio.org, is a great place for reference and diving into more of the details. So we've gone through the architecture specification. Again, this is the really fast version of OpenHIE architecture. We've very quickly gone through the framework for the client registry specifications within the components. And now for the data exchange specifications, we've already talked about the 4 core workflows that must be supported. Here's another one that needs to be supported, the query by demographics workflow. And again, we specify which transactions, including FIRE transactions, should be supported to support this system. We also have reference technologies listed within OpenHIE, and this doesn't have a nice upfront URL, but you can you have the URL right here if you'd like to scroll through more of these. This is just a screenshot. I can tell you that we have, there are more than just 2 reference technologies for the client registry, but we have seen some good work being done by the OpenCR community and the GemPI community. I know that GemPI is doing some implementations, I believe, in Kenya right now, and they've actually recently done a presentation through our data use community regarding that work as well. OpenCR has been implemented in a variety of locations as well. So these are 2 examples. There are other examples that you can look at on the website itself. So that's a very high-level overview of how the system works. I do have some other just additional considerations that are important to think about within the context of a client registry or patient identity management. I think it's important to recognize that when you're thinking about your matching strategy, so you have an architecture, you have a functioning specified technology, you have to think about what elements are you going to use for matching. And there's a lot of different approaches to matching, from unique identity, unique IDs assigned, to demographic rule-based matching. But the identifiers that we use for matching, their ideal characteristics are, as you see on this slide, they're unique, they're ubiquitous, they're readily available, they're unchanging. And so we want the identifiers to be stable. They should be uncomplicated. So we certainly don't want to have a human type in a 32-character ID. That's, of course, not going to work for a variety of reasons. We want it to be uncontroversial. And what is uncontroversial varies depending on your location. It depends on the regulatory framework that you're operating under. And then I couldn't find a U for the final one, so I just said easily and inexpensively accessible. So those are, and the reality is no single identifier meets all of the ideal characteristics. So you have to make some trade-offs in that as you're considering what your approach is. the universal patient identifier, which is becoming increasingly popular. And I've learned over the last few days that the Philippines is doing some great work in that area, as I'm sure other countries in the AHIM community are. Obviously, it can simplify matching and increase matching accuracy. Accommodating lost or unavailable IDs is certainly something that needs to be contemplated. In some regulatory contexts, people are concerned about government identifiers, but in other contexts where there's high trust, they don't. Just looking at the time here, it looks like I have about 8 minutes left, if I'm correct. Biometric identifiers are certainly of interest and available. And certainly we see fingerprint, voice, retina, vein scan, face identity, often used in conjunction. They're mostly unique, as you can see I've put in there, because sometimes there can be, overlapping fingerprint traits. It's incredibly rare. And biometrics in general are highly specific to an individual. They can be a little more expensive and require some proprietary solutions that may not be standards-based. So those are a couple of the challenges to think about. With patient matching algorithms, you're using relatively readily available identifiers, but matching algorithms are also imperfect. There could be false positives and false negatives, and it's highly dependent on data quality. So those are some of the strategies, those are some of the matching approaches that you might see implemented in these various matching systems. In general, I believe, and I've seen most of the commercial matching systems that I've worked with support a spectrum of approaches from unique IDs to demographic matching. And I think it's important that client registries have that flexibility to adapt to different locations with different requirements. I want to talk just a little bit about the technologies that we see moving forward. We're seeing improvements in matching algorithms. Dr. Ong and I are working on a project together using large language models to augment patient matching and patient matching review process. Biometrics continue to improve in effectiveness and accuracy and usability. National unique healthcare IDs obviously continue to be contemplated and of broad use. I want to talk about a couple of technologies that I think are important to think about. We're seeing biometrics expand to our wearable or mobile devices, and so people are becoming more comfortable with them. Biometrics really represent access to a unique token, and we're starting to see unique identity assigners like ID.me and other identity authorities who can leverage biometrics to access a given identity token. So we're beginning to see the ubiquitous technology available enable the use of unique identifiers through biometric authentication. And I think we're going to continue to see more and more of this. Referential patient matching uses many different versions of a patient's data as much as possible for algorithmic matching. In the United States, I've done some evaluations of various commercial systems, and I've seen that referential matching algorithms tend to be the most accurate and require the least upfront configuration. In this example, you have a patient, Pat Williams, and their identifiers there. So Pat, he may, don't know a lot about him, but then, oops, we see a Patricia Jones, female, etc., dates of birth, etc., and we start looking at these, and we can put together some patterns. So females might change their last name. We know that the Patricia Jones is a female. Looks like there's a misspelling in the address, but they're highly similar. And the date of birth, there's a typo in the year of birth, but otherwise it's aligned, and the telephone number is spot on. So if you only had one of these records, you may not a referential data set contains both of these as a reference for matching. And so a referential matching algorithm would already have these pieces of information. And so they can stitch that sometimes confusing, questionable, or incomplete data together. So excited about that approach. And finally, and Toan, if you want to talk a little bit about privacy preserving record linkage, we're seeing this increasingly used for matching. Toan, I don't know if you want to just speak to like 60 or 90 seconds on PPRL.
Yes, absolutely. Thank you, Shaun. So, privacy preserving record linkage is the solution to allow the performance of linkage of data across different data sources, as Shaun mentioned, securely with respect to patient privacy. This process allow you to link records without reviewing the identities of the patient. As you can see on the diagram there, the main component of PPRL or privacy preserving record linkage is the hashing process. And in that process, the hash function will convert the clear text value, like a first name, into a what I call a hash values, or a nonsensical value that cannot be reconverted to the original values. So that's the benefit of the hash function, to turn it into something that cannot be reconverted to the original values. However, one of the feature of the hash function is when there's a minor or a single difference in the original input values, the output value will be completely different. That makes it secure, but also challenging in terms of matching. And so I'm looking at the second diagram there. So when there's the need to make sure that when that typographical error, for example, in the original values, you still be able to compare the output values. So Shaun, I don't know if you want to go deeper, but that's basically the overview of the privacy preserving linkage approach.
Sure, yeah, and that was great, Toan. Thank you very much. Again, I think this is an important emerging topic that Toan has been very actively engaged in, and it's becoming increasingly used here in the States to integrate data together when organizations who are sharing data might not have as much trust, or they have some concerns about risk of sharing data or integrating data. Privacy preserving record linkage is one way to mitigate that risk, and we're seeing it increasingly used more and more. So that brings us to the end of our presentation. But before I go, I just want to remind everybody that the 2024 OpenHIE community meeting is going to be in your hemisphere, nearby, in Colombo, Sri Lanka, and would love to see many AHIN members at the OpenHIE community meeting if you are available to go. So with that, I will turn it back over to Cha, and we can proceed.
Yes, thank you for the presentation, Dr. Shaun and Dr. Toan. Before we entertain some questions or comments from our participants, I'd like to call on our panelist for tonight, Mr. Francis Oy, CEO and co-founder of Sinag Solutions in the Philippines.
Okay, so thank you, Cha. Hello, everyone. So I was asked to provide a reaction to the discussion of client registry from the OpenHIE. Thank you, Dr. Shaun and Dr. Toan. So I was part of the enterprise architecture team who updated the Philippine health sector enterprise architecture, and we got our EA approved last December 2023. And then we're now working towards making sure that the components of that architecture are slowly built and they become a practice, become the de facto processes and systems that we have. The Philippine Health EA is very much consistent with the OpenHIE, and we've been part of the conversation since early 2012, 2013. As Dr. Shaun mentioned, the Philippines also, we are in the process of fully deploying the national ID. This is a foundational system for Filipinos, and effectively, Filipinos who register there will have their own unique ID. 50 million of them have been given cards already that they can use as their identity. But more importantly, it has their biometric data, such as their fingerprints and some key demographic data, so that it is able to identify every unique Filipino in who will be availing of these government services or of these health services in the future. To date, we've heard about 80% of the target citizens have already registered to this, and they can already use the whether digital or the printed QR codes to verify their identification across all the different establishments in the country, because by law that needs to be honored across all establishments. And so this also has some fraud detection. So in terms of finding the same person who may register more than once, even if you registered in different provinces, the system will tag you as a potential risk that then you now need to address and manage if you do that. In terms of the health EA and the client registry, we see multiple use cases for us to make sure that this is fully implemented as mandated by our Universal Healthcare Act of 2019, or RA 11223. We see this use case across ensuring that healthcare provider network across health facilities from primary care, they're able to refer patients to tertiary hospitals and able to transmit their health records appropriately with the right person involved, or even enable a more localized health management for health concerns across a province or a city. Once we have the properly uniquely identified health records, we'll be able to enable that decision making and support at the provincial and health level. And then finally, the last use case that we see having a very mature client registry for our country is in ensuring that we capture the right health data in our national health data repository. In doing so, we'll be able to see a national view of all of our health trends or health patterns that we need to address from a policy perspective or from a management perspective. Thank you so much for this opportunity to provide a comment.
Thank you, Sir Francis. So now we'll open the floor for questions. If you have questions, please feel free to enter them in the chat box or in the Q&A box. Our first set of questions is from Dr. Aminul Islam. His first question reads, which scenarios or health system ecosystem, particularly OpenHIE, is best suited in comparison to TOGAF or federated architecture?
Sure. I can tell you that OpenHIE, its generalizable framework has informed most of the existing e-health architectures out there. I think TOGAF and others will emphasize or expand on particular aspects of the architecture. Again, OpenHIE was designed to be pragmatic and practical to create strategies for implementing real-world systems, providing exemplar software to illustrate the strategies and approaches. And so OpenHIE focuses on those very real-world clinical workflows. Again, to describe OpenHIE, it takes much more time than we have today. but I think that you will find significant relationships between the various architectures. Again, I think fundamentally, whatever eHealth architecture you're thinking about, if you want a comprehensive, robust eHealth architecture, you've got to standardize and manage those core types of data that I went through earlier very quickly. And so you can ask the question, how am I going to standardize or manage patient data in using different architectures? You'll find that the client registry we've talked about, I think, fits into each of those architectures. Now, there's a lot of other layers to this besides the technical, including privacy and security and policy. And while OpenHIE addresses that, we recognize that there's going to be significant variation across different regions and countries, strongly informed by your regulatory framework. So they're related to one another, but I think they take slightly different, they touch the elephant at slightly different points.
Thank you, Dr. Shaun. Dr. Aminol's second question is, what are the key benefits of OpenHIE architecture in general?
Sure. So OpenHIE is a community-driven process. It reflects the needs of its community members. And so, as I mentioned earlier, it reflects the pragmatic, practical, real-world approaches to developing plans, strategies, and implementations. It does not overspecify where we believe there will be high variation among different regions. So I think if you study the OpenHIE architecture for an hour or two, I think you will have significant insights into what will ultimately be your strategy for deploying an eHealth architecture. It covers the key points of the architecture. And we recognize OpenHIE has been around for about, over 12 years now, I think. What we've recognized over time is that we want to achieve consensus where consensus is possible among the community, and where there is more variation on consensus, again, for things like privacy, security, policy, we tend to de-emphasize that. But I think OpenHIE and its related resources can help individuals to craft a strategic plan, and individuals can learn from the resources, including there's implementation guides, as well as exemplar reference software.
Thank you, Dr. Shaun. Our next question in the Q&A box is from Dr. Niels Kaiser. Thanks for the presentation. How does the client registry specification from OpenHIE relate to the standardized IHE profiles patient demographics query for mobile and patient identifier cross-reference for mobile, including the patient demographic match ITI 119 specs?
Sure. So I am going to share my web browser. Share, can you see that? So I'm at the OpenHIE site right now, and I'm going to go into the component specification down to the client registry, and you can see these workflows. So creating a patient demographic record. Now I'm going to go into the more detail, because this is a detailed question. So here are the specific standards used or supported by the OpenHIE community. And if you go further, you can see in greater detail the transaction options available, because we have, when OpenHIE started, HL7 v2 was the predominant transactional standard. And in many places, for example, in the United States, HL7 v2 still conveys over 95% of all healthcare data in the US. So V2 continues to be a real world, practical, important, even though we all want to move to the FHIR, it's important. But we also do support FHIR transactions as well. And so we point to the specific IHE profiles that we recommend. And in fact, if I believe if I click on this, it'll take you right to the specific profiles that we support for that particular approach. So I didn't answer your specific question about which specific profile, but what I've done is I've given you a place where you can go and very quickly identify whether the profiles you're looking for or reliant upon are supported and referenced. And if they're not referenced, and you'd like to get engaged in the OpenHIE community, we would love to hear the needs that aren't being met today. So there you go.
Thank you, Dr. Shaun. I'll go through the questions in the chat box now. So this one is from Dr. Alvin. If we mistakenly link or merge Alvin 123 to Alvin 456, is it easy to adjust and merge them, or will there be risks?
Oh, Alvin, you asked such easy questions. So unmerging is probably the most complex transaction with patient matching. And so many systems, so there is a merge, unmerge transaction supported in the HL7 V2 profile. I'm trying to think of where it is in FHIR, but it's hard. Even though you might have a standard for supporting the reproducing of two identities, once identities are joined, it's from an information perspective, separating the identities again is the easy part. Determining which clinical data belongs to which identity afterward is very challenging. So it's a little bit, I don't know how many people have had to deal with unmerging records, but it really is, it's almost counterintuitive. Separating the identities again is fairly straightforward because you can usually replay those identities. You know, you usually have transaction logs, some sort of history of the change, but all of the clinical data that's come in needs to be rectified. Usually we can tease them apart by time because you know when a merge occurred, but the challenge is after that time you don't know which record which observation belongs to, and that takes some sleuthing. That's quite challenging to do. So there isn't an easy answer to your question. There are standard transactions to support those processes, but the real world challenge is not in the standards or transactions. It's in the approach to teasing apart data after the merges happen. Over.
Thank you, Dr. Shaun. Dr. Alvin has another question. After downloading the client registry specification from OpenHIE and we decide to customize it for our country, do we need to get permission from OpenHIE to do so?
Oh, no. I think that many organizations have used OpenHIE as inspiration to create something that's useful and meaningful for their country. And we encourage that. That's why we exist. If people can use the OpenHIE specification in whole, that's outstanding. If folks need to adapt, modify, evolve it for their particular circumstance, that's wonderful too. The OpenHIE community wants to be helpful. We want to share our learnings, our experiences, what has worked for us with others. And we know that what has worked in the past and for others may not completely work for you. So I just want to emphasize we want you to take this material and we want you to make it work for your setting.
Thank you, Dr. Shaun. Our next question in the chat is from Dr. Pablo. For a scenario of data exchange between continents, what would you suggest as a patient identification mechanism for searching in indexes of other countries? There are IHA profiles for exchange such as XCA and MHD, but the question is oriented to what identifiers or personal data you consider necessary to launch such searches.
Sure. So this type of question applies not only to cross-country matching, but it applies within a given country. You have different states, different municipalities, different healthcare organizations that may capture different identifiers. What I see as happening is people are thinking about designing the transactions, and actually HL7 now supports it. You can have multiple identifiers for the same person. And so the general approach would be to, and there's a lot of detail under this, but the general approach at a high level would be to allow for multiple identifiers to be associated with the same person, because it's going to be very hard to align different countries on the same identifier. But if two different countries want to share data and there's a need and a desire, in the easiest case, which is almost not worth talking about, would be you lo and behold have two countries with the exact same identifier scheme already implemented in their healthcare system, and so it's simply a matter of treating the new country as if it were part of, if they were conjoined as one. But the reality is there will be different identifier schemes, different meanings of the identifiers, different fields will have different discriminating power, and so you'll have to reconcile those approaches. And so there is no one size fits all, but the trend I do see is increasingly deliberately enabling your transactions and systems to accommodate multiple unique identifiers. Here in the US, for example, as we grow out our national e-health exchange through TEFCA, we have different RHINs, regional health information networks. They identify here in the US, these regional networks identify patients differently. And so one of the approaches we're starting to take, and this was actually developed by Commonwealth, which is one of the organizations, was basically to say, okay, give us your driver's license if you have that. Give us your medical record number if you have that. Give us your social security number if you have that. Give us, any unique identifier that is highly discriminating, we'll take and use. And so the answer to your question, again, is deceptively complex, but being flexible to accommodate multiple identifiers, I think, is key to the strategy. Over.
Thank you, Dr. Shaun. Our next question in the chat box is from Dr. Jameson. He says, we have 7 layers of protection in the US. Is it in line with the US HIPAA versus OpenHIE?
Oh, yeah. So HIPAA specifies technical and administrative controls that need to be in place. IHE profiles ensure basic security measures are taken, but transactional specifications like OpenHIE supports don't specify all of the technical controls required for HIPAA. In the same way, every healthcare organization needs to establish its administrative controls and all of its technical controls. Okay, how is access to the system, the overall system, firewalled, controlled, and maintained? And so there's a reason why we have, so most healthcare organizations not only follow the HIPAA guidance, which isn't precise. When it says administrative controls can be different at different organizations. technical controls. We have many different security certification levels that aren't HIPAA. We've got FISMA and HITRUST and other security certification standards because HIPAA doesn't specify all of those. But OpenHIE is entirely aligned with HIPAA, and it works well with any of the security certifications because they're really supporting and enabling of the infrastructure. Over.
Yes. Thank you, Dr. Shaun. Our next question is from Dr. Asif Atik. Can we store the demographics as vectors or graphs and match them in the duplicate?
Oh, sure. Yeah, that would be a matching approach. And in fact, one of the other reference client registries that used to be on the list was OpenEMPI. OpenEMPI has a graph-like infrastructure to be able to support a variety of matching approaches. We believe when we started building out the master person index for Rwanda, we realized that we needed to be configurable but fast. Configurable but fast data models tend to lead you towards graph data models. Once you have the data in a graph model, you really have the best of both worlds. You can leverage graph-based algorithms, and you can leverage all of the previously existing fields as well. So absolutely, I think there's no question you could leverage that. OpenHIE does not specify the matching algorithm. It says that you need to have one. It needs to be configurable and manageable and measurable. But we recognize that there can be different algorithms that may work in different circumstances.
Thank you, Dr. Shaun. We have another question. This is from Dr. Carol. For the client registry, do we have OpenHIM specifications?
I'm sorry, OpenHIM is the mediator. So if you remember in the diagram, there was the interoperability layer. Yes, we have, and we've had representatives of OpenHIM active participate in the OpenHIE community. To the extent, I don't recall the extent to which we have documentation regarding the interoperability layer. I haven't looked at that in a while, but so I know that we specify, for example, that ATNA needs to be supported, and you generally support the IHE ATNA profile in the OpenHIM, in the interoperability layer. But if you'd like, I'd be happy to follow up with you and point you to additional information.
Thank you, Dr. Shaun. I'm just rechecking our chat box if there are other questions. I think we have a question here from Dr. Jameson. His question reads, how strict is the RA 11223 in contrast with the US HIPAA?
I don't know the first one, so I can't do the compare and contrast. Is there someone else? Maybe I know Alvin probably has experience with both. But I can't.
Shaun, this is Alvin. I think the HIPAA is American and the RA 11223 from the Philippines, the Data Privacy Act is UK pattern. So, but I think they're similar, more or less. Or
yeah, HIPAA. I mean, it turns out I was a bit disappointed. So once I dug into HIPAA, you see that it is truly a framework. There are some specific requirements for securing data and ensuring data is private and confidential, but you can achieve those goals through different means. And so HIPAA is really a framework. And fundamentally, that framework works if you don't have any data breaches, any data leaks. That's sort of important. That's a key measure. There's other measures, but and there's some good resources on HIPAA out there. If people are interested in resources, I can point you to them.
All right, I think that's our last question for tonight, and we're also reaching the top of the hour. Once again, thank you, Dr. Shaun and Dr. Toan, for making time to present in tonight's webinar and for accommodating the questions of our members. We'd also like to thank our participants for their active participation. Thank you also to Sir Francis for participating as a reactor in tonight's webinar. Before we go, maybe we can take a group photo. Please turn on your cameras if you wish to join.
Shaun, thank you very much, Toan, for joining us tonight, and Francis. I think we should have this regularly because everyone needs to get in
Yeah.
sync of what's happening to each other and how the countries are implementing client
Yeah.
registries and OpenHIE. Over.
And I do think it would be helpful. The privacy preserving stuff, I think, is important for people to understand as a tool in the toolkit. So I would.
Let's schedule that one, Shaun, sometime, maybe October.
Toan's your guy there.
Okay, Toan. All right, we'll sync up offline.
Thank you, everyone.
Take care now. Bye.
Thank you, Shaun. See you around.
Bye.
Bye, Toan. Francis, salamat. Thank you.
Thank you, everyone.